59-year-old male, progressive dysphagia many years, high Eckhart. But there's something about this case. Yeah. Normal IRP. No peristalsis. Frequent pressurizations, but normal IRP. So something's off. Something smells a bit fishy. So first thing, more bubbles in the esophagus. If you think that this is normal, just think about it the next time you do a few gastroscopies. It's not so normal to see lots of bubbles in the esophagus. Stomach, yes. Esophagus, not. Very tortuous. Lots of saliva pooling in the esophagus, and the mucosa, a bit like your skin when you've been in the bath for too long. Very wrinkled and very chronically static. And then the junction, very difficult to pass. So everything you'd want for a typical achalasia. So Xander, I missed, can you just repeat the other investigation findings? Yeah. So the gastroscopy we've just done.
Yeah,
the
so
swallow.
The swallow, the barium swallow showed a very, very slow progression of the contrast and stasis in the distal esophagus, with the dilation of the esophagus.
I suppose the learning, again, it's the same as yesterday. It's about overcoming problems.
What problems were there in this one, in your view, that we had to overcome?
Well, I think the biggest problem was that you couldn't extend your tunnel as far as you wanted to without commencing the myotomy.
Yeah. And I think, yeah, so let's talk about that specifically. So it was when we, before we did this, so we're getting down into the situation where here's the muscle line, it's starting to pull off. I'm putting so much pressure on it. Here's the mucosa. So we talked about muscle meeting mucosa. It comes around here like that. And then when I'm injecting and then I'm proceeding, I'm having to have the knife way out in front of me. Like this is like, so here's the mucosa right here. So one more tap on that and it's a hole in the mucosa. So, okay, there's that. Also, I'm injecting out of sight, not because I can't get there. And I do think it's necessary to do a bit of this, because if you didn't do this, it would have been very, very difficult to do the bit I did later. So it's important to do a bit, but when you get what starts to happen here, which is me kind of pushing in and then a little bit more maybe. A little bit further.
So that little extra bit allowed you to find the plane again.
Yeah, that's true. But then it got to this stage where, like, I'm cutting here. You see it here. Cutting, I'm going through the muscle without knowing it. I've got no angle on it at all because the muscle is going around here. So that's actually what happens when you're not in plane and when you're not pushing in enough. Just as an extreme example, but when you're not pushing in enough, if the muscle is actually dipping below where the tip of the scope is, then you really can't get in the plane properly. So, okay, then we decide to do the myotomy. So we go down, 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 down. And then you get to the point where, not here, but probably the end of the tunnel is now just out of sight, maybe. Yeah, so end of the tunnel is kind of there. And here we're doing myotomy, right? So at that point, you have to do something else, because if you carry on so that it's totally onto your, so there's not a pocket here anymore because you've cut this muscle, it's very, very hard to get back in the plane. So you must do it before you get there, that you then reestablish your plane, and then all you have to do is sneak underneath and start cutting start cutting these fibers off a little bit, like, just be very careful of the mucosa again. Same thing, etc., etc. So yeah, you could get back in plane, and it worked, didn't it? In the end, it worked that we could cut a bit more of the muscle, and then we see clearly the palisading vessels here. We could go beyond that and can cut the muscle. Yeah. So indeed, that was something different about this than the other procedures. All right.
Thomas, something you saw different about this than the other procedure?
I was just wondering because, I mean, probably it can be easier to extend the tunnel beyond the junction, but I mean, it'd always be a little bit tricky at that part. So why wouldn't be? I'm not asking why we should do it every time, starting to cut and make probably having easier access to the space beyond the junction. But is there any space you think room for use this technique more often? Or?
It's just difficult to do. Like it's difficult, and therefore, like everything, you don't want to do something difficult if you don't have to. It's much more difficult, and I think the number of times when, I mean, you've kind of seen it nearly twice today. It's not so common actually that it's so tight on the junction. So no, I don't think you should do it unless you get to this situation, at which point then it's a very useful way to solve it.
Yeah.
Any other comments on technique here, that stuff that you haven't seen from the previous cases? Ulrika?
No, sounds Karen's. It's a new idea for me.
Yeah, okay.
Mainly.
Danda, something you saw here that you didn't see in the previous ones?
Well, starting on myotomy before you actually were comfortable and deep enough into the stomach with your tunnel. I haven't seen you do that yet. So
I think that's what the others are saying. Yeah, okay. Mary, something you saw here that you hadn't seen before? Same, okay. So then you were doing my other work for me, thank you. Lynn, something you saw in this case that you haven't seen in the other cases? Surprised none of you said the very obvious thing. There's certainly very obvious thing that was different about this one than the other one, but did you have some comments on it? Maybe you weren't watching the whole thing.
No, I unfortunately haven't.
Okay, I understand. So what was different for me was the absolute thickness of the muscle. So that was very different here, wasn't it, to what we'd seen before? And when you look at it,
And immediately.
yeah, very, but not. I think very quickly. Yeah, not immediately, but then it was very quickly. And so that does necessitate a different approach, right? You cannot, in this case, always do one side to the other or one to the other. So you see, I'm doing this technique of starting a little bit under, but not on it, and then kind of lifting up like melting cheese through the muscle, which is not what you saw before.